Based in Portland, Oregon, Central City Concern has a 40-year history of serving individuals experiencing or at risk for homelessness. Annually, we serve over 13,000 people. Our mission is to help those struggling with life's biggest problems to end or avoid homelessness and build healthy, housed, resilient, and engaged lives. Our healthcare division is an FQHC with a special designation to provide services for homeless populations. We operate 13 sites with integrated primary care, comprehensive mental health, and addiction services. We offer low-threshold, same-day access to opioid use disorder treatment with both residential and outpatient options. Our Hooper Detox Stabilization Center is a common entry point to our recovery care pathway. In fact, more than 25% of all clients coming to CCC for services enter through the front door of our detox center. In addition to our FQHC, we operate a housing division for individuals exiting the street, shelters, detox, incarceration, and hospitals, to name a few. We provide housing for over 4,000 individuals across 28 properties, offering a range of options, including low barrier, recovery, transitional, and permanent supportive housing. The third leg of our integrated stool is jobs. This includes a large team of integrated employment specialists embedded in our housing and healthcare programs. With that high-level overview of Central City Concern, I'd like to now turn to the challenges we faced and still face during the COVID-19 pandemic. We first needed to keep our clients, staff, and surrounding communities safe, despite close living quarters and shared living facilities. In addition to the COVID prevention protocols that you would expect, we needed to develop the capability for rapid symptom identification, testing, isolation, and quarantining. A significant barrier we faced is the inability to efficiently coordinate care. 42 CFR Part 2 limits our ability to share critical information between and among health and social services care team members. To overcome this challenge, we implemented Central Worklist from Enly Health Intelligence, now part of Cedargate. This flexible care coordination solution allowed us to integrate data from our housing tenant management software with COVID testing status from our health services division, while minding the boundaries of data privacy. In addition to using Central Worklist to track COVID testing status, we were able to coordinate all the necessary health and daily living support for the clients in quarantine. We tracked everything from symptom monitoring to food sufficiency to dog walking schedules. The second significant challenge that we faced was enabling our clients to continue connecting to critical services. COVID's second wave of harm is the damage resulting from social isolation. We have seen a surge in substance use, relapse, mental health crisis, and overdose. The need to connect is not limited to health-related services. Families need to connect with their DHS workers. Re-entry clients need support from their parole officers. Typical harbors of connection, such as clinics and libraries, have been cut off due to COVID prevention protocols. To address this need, we equipped our clients with access to technology in various ways depending on the setting. Thanks to funding from Care Oregon and Trillium, we were able to provide outpatients with data-enabled mobile phones. Thanks to a grant from the NATO family, we were able to provide iPads to moms in residential recovery services to support their ongoing individual and group therapy needs during COVID quarantines. We also installed web pods in 8 buildings. These are freestanding and soundproof, self-contained, unstaffed, web-enabled booths equipped with laptops. They offer a clean, calm, and private space where residents can virtually meet with their providers, recovery coaches, and other needed services. Chromebooks were purchased with funds provided by Intel's Pandemic Response Technology Initiative, a program designed to combat the effects of the coronavirus pandemic through increased access to technology. One of the key takeaways I'd like to emphasize today is that CCC stood up all of our telehealth efforts within 1 week. Prior to COVID, CCC didn't have any of this technology in place. In the first 2 months of 2020, we provided 0 telehealth visits. By the end of March 2020, we had provided 2,800 telehealth visits. 1 month later, the number more than tripled. By the end of 2020, CCC provided nearly 25,000 visits, and in 2021, we provided over 50,000 telehealth visits, doubling our capacity. I'd like to end by saying all of the telehealth and virtual options that FQHCs like CCC have put into place were made possible as a result of the federal government making temporary changes under the current public health emergency that allows clinics like ours to expand into telehealth services and develop unique partnerships to best utilize technology to connect people with services.